Hola a todos. En el contexto del Congreso, del PreCongreso del Instituto Cardiovascular, tenemos la oportunidad de estar con una eminencia en cirugía cardíaca mundial, el doctor Tirone David. Me acompaña el doctor Fernando Piccinini, que es staff del Servicio de Cirugía Cardíaca. Es un momento muy importante, no solo para la comunidad de cirugía cardíaca, sino para toda la cardiología, por lo que significa el doctor Tirone David a nivel mundial y toda su trayectoria. Así que nos pareció muy útil tenerlo y le agradecemos. Ya estuvimos charlando previamente su aporte, y la idea es tomarnos una primera parte donde el doctor Piccinini va a interactuar con el doctor Tirone David sobre válvula aórtica, y la segunda parte trataré de hablar con él algunas cosas importantes en cuanto a lo que es el impacto terapéutico de la reparación de la válvula mitral. Okay, Tirone, after a short Spanish introduction, again, thank you very much for being with us. We're going to start with my friend, my staff coordinator, Dr. Piccinini, next to me. We're going to start to discuss regarding aortic valve problems. And then the second part, as I mentioned before, so mitral valve repair. I think it's Dr. Fernando is going to start asking you questions.
Dr. David is a known pioneer on aortic valve preservation surgery. You are one of the developers of the technique. So the first question is, what are the rationale, what are the fundaments behind aortic valve preservation for the aortic valve specifically?
Well, it's like mitral valve repair. Because you don't have a perfect heart valve substitute, you have to try to repair diseased heart valves. But of course, you have to have a balanced view. You can repair just about anything, but how are the outcomes? So the outcomes of valve repair must be better than the outcomes of bioprosthetic valves. And that's my bar. So whatever you do in repair, you expect the outcomes, long-term outcomes, to be better than the bioprosthetic choice. Is the lack of a perfect valve substitute that prompted most of us to develop techniques to preserve the native heart valves, all the valves.
So is that what you is going to be your first indication for any kind of patient, or is an age threshold for the indication the valve repair?
Oh, I think there is an age, of course, because remember, older you are, whatever you do to the aortic valve, you're going to compete against a bioprosthetic valve that may last the patient's lifetime. And this is particularly true for patients older than 70 years. In North America, we stopped talking about age. We are talking more about lifespan. Anyone at any age now who expects to survive more than 15 years is no longer old, because whatever we do to the heart, we expect to last the patient lifetime. So lifespan of 15 years is our cutoff now. If you do a valve repair, you expect the patient to be free of problems for at least 15 years.
And so when we discuss about it, the first issue is long-term follow-up, durability, reoperation rates. So what are your thoughts about that in your experience of your own technique?
We don't look as much as age as we use a pathology. Wednesday or Tuesday, I had to replace an aortic valve in an 18-year-old with a mechanical valve, because the pulmonary is abnormal. I could not do the Ross procedure, and I could not save an aortic valve. It was so malformed that we ended up doing a bento with a mechanical valve. She has Turner syndrome, and we thought was the best therapy for her. So it's not as much age as it is the quality of the aortic valve cusps. The same thing can be said about mitral and tricuspid. You can repair any valve if the cusps or leaflets are in good quality. That's why echocardiography prior to surgery is indispensable to select patients for valve repair. And now with transesophageal echo, and sometimes three-dimensional echo, we can pretty much tell the patient with a 99% certainty if the valve is repairable or not.
Okay, I agree that a preoperative echo is a key point on being successful on repair. So with that in mind, which is a patient you should not repair?
If the valve is
echo findings.
leaflets or cusp are calcified or restricted on transesophageal echo or thickened, if you don't think it's going to be a good device to close the aortic orifice, the same is applicable to mitral and tricuspid valve. The crucial thing here is the quality of the cusps. You can do anything with the root to the annulus. You can shorten the cusp if it's too long. But the moment you add the material to a cusp, you short the durability of the repair. We don't have a good patch material. And I tried them all, believe me. 40 years in practice, I tried from fresh pericardium, glutaraldehyde fixed pericardium, decellularized pericardium, core matrix, Gore-Tex sheets, polyester, nothing lasts very long. They're all great in the operating room. They're all perfect every 1 year. At 5 to 10 years, they begin to fail, just like the bioprosthetic valve.
And what about the bicuspid one? Is this an extra issue to repair in the bicuspid valve?
Bicuspid is more complicated because the phenotype is so variable from patient to patient. The truly bicuspid aortic valve with 2 cusps and 2 sinuses are perfect for repair. The Siever's type 1, we have fused 2 cusps and 3 sinuses. It's more complicated. Closer they are to a truly bicuspid, better for repair. Closer they are to a tricuspid valve, it's more difficult. And sometimes what we do, we transform a bicuspid into a tricuspid if the fusion is not very extensive, only 2 or 3 millimeter.
Okay, and last question. Imagine we fail, you don't fail on repair, we fail, and we have to change the valve. What kind of, is a 50 years old who doesn't want to be on anticoagulation? What kind of bioprosthesis would you suggest to use and why?
I think porcine valve, in all the porcine valves, the Hancock valve has established durability in the aortic position. The only problem with the Hancock valve is that it is obstructive. So it's no good in small sizes. Don't bother implant at 21 or 23. But if we implant at 25 or at 27, Hancock 2, doesn't matter what age, you're going to have a patient with a competent valve for at least 15 years. If you're over 60, likely for the patient's lifetime. So having said that, I still use Edwards Magna because hemodynamically is better than the Hancock, particularly smaller sizes, 21 and 23 and 25.
Okay, thank you very much. We move to mitral valve now.
Okay, thank you. One of the questions that the cardiologists are very concerned to deal with a symptomatic patient with mitral regurgitation, asymptomatic. Which time the timing to go to surgery, and which is your thought about that to send the patient to surgery with asymptomatic?
Well, I can tell you that in the past decade, I do approximately 100 to 120 mitral valve repairs a year. 80% are class 1, have no symptoms. But they all go home with a competent valve, and have seen our results. They don't fail very often. So I think in mitral valve repair, like aortic valve repair, is a specialty. And if you can provide repairing over 99% of the cases, every patient who has severe mitral regurgitation due to leaflet prolapse should have mitral valve repair. Of course, if you're 75 or 80, the benefit of survival is diminished. But the average patient is 50 or 60. Those patients have a survival benefit by having a mitral valve repair while they are asymptomatic. We have demonstrated symptom alone shorten the lifespan. In other words, a patient who has mitral regurgitation and develops symptoms is a marker or something bad in the heart, not only the amount of regurgitation.
Yeah, usually when we had symptoms, sometimes it's too late. And the other thing is, if your patient, you need a TE, or you pay attention at echo TE before surgery or before a symptomatic patient to rule out is the valve disease or is a P2 prolapse. It is a concern to you. We had to pay attention about that before surgery.
Depending on the quality of the transthoracic echo, the transthoracic echo is clear. It can get good images, and there's a single or two segment prolapse. That's the end of the investigation. However, if they have a complex pathology, they have an annulus of 50 millimeter. I don't know if there's calcium or not in the annulus. Then I do get a transesophageal echo in asymptomatic patients to guarantee that I can repair. If the patient is symptomatic, class 3 or 4, doesn't matter. They're going to require surgery anyhow. So whatever you do will be beneficial to the patient. But the asymptomatic one, I think it's important to make sure that you can repair the valve. And a TEE is very helpful.
Yeah, how is the situation in terms of reparability in your state and in Canada? I'm sure there's not the same incidence of repairability that you have. How the percentage of reparability in your area?
So it's a problem. We have a database in Ontario, and only about 60% are repaired, 40% are replaced. But luckily, the patient becomes smarter here because of the internet. So they are looking for answers prior to surgery, many of them.
You just a couple months ago published a very important article regarding the long-term follow-up on mitral repairs. Want you to talk about a little bit about all the results of your paper, and also if you think for maybe not for you, but if the durability, the results of the repair is the same of P2 or anterior leaflet or bi-leaflet in the long run.
I think most surgeons, people that we train, can do a P2 repair as good as me. It's a relatively simple operation, whether you use a resection or a bunch of Gore-Tex. The problem is that more often than not, a P2 is not only P2. Once you go inside the patient, you explore the valve carefully, and then suddenly you see that other areas have a flimsy chorda tentina or minor prolapse, but no regurgitation in those areas yet. So if you ignore the rest of the valve, if you go in, do a P2, and don't inspect the whole thing, likely you're going to be burned next 5 or 10 years with recurrent mitral regurgitation. So simple repair, I think anyone can do and should be able to do very well. The moment it becomes bileaflet, commissural area, it becomes more complicated and really becomes domain of a person that operates there often. I mean, unless you do one a week at least, it will be very difficult to become an expert on complex repairs. But again, I can let my residents do a P2 and the results are identical to mine. But it is my judgment that is doing the operation with the resident's hands. It's a different story.
Okay, what about the incidence of atrial fibrillation in the long run or recurrency of the long run regarding your last paper that you published in the JACC?
That's puzzling, and we ran, it's a pretty large number of patients, 1,200 patients. We are now doing my entire experience. We are hopefully by later this year or next year, we're going to have the outcomes of 33,000 patients follow up to 30 years. And it looks like atrial fibrillation is a marker of myocardial damage as well. In other words, in patients that have no symptoms when I operate on them, or the ventricular function is normal after the operation, they never develop atrial fibrillation or tricuspid regurgitation. Usually, our patients have impaired ventricles or very large atrium that develop atrial fibrillation. And unfortunately, one variable cannot change, getting old. All of us with mitral valve disease or not, by the time you're 80, 30% develop atrial fibrillation. So it's a pretty prevalent disorder.
Okay, one question, a technical issue. I remember when Carpentier described all the initial techniques, the quadrilateral resection for the P2 was sort of the most important technique. After the introduction of the artificial chordae, changed the scenario and start to think about respect and resect. What do you thought about the contribution of the artificial chordae in the repair now in the 20th century? You think it's changed all the techniques?
I don't agree with this approach of respect rather than resect. I think both techniques have a place in floppy valves, in myxomatous mitral valve. You have to resect certain segments. If they are voluminous, if they are calcified, if they are very thick and fibrotic. However, in patients who have a fibroelastic deficiency or very minor myxomatous change, you should never resect. We should keep as much leaflet tissue as possible and correct the prolapse with the chorda tendina, with the artificial chorda. So we use both techniques. We tend to preserve more leaflet than usual. In other words, unless the posterior leaflet is too tall, more than 20 millimeter, we use Gore-Tex only. If they are more than 20 millimeter, we tend to resect mostly to shorten the height of the leaflet to prevent SAM.
Okay. Tell me something about tricuspid regurgitation. I know that you had a nice debate with Dr. Adams a couple of years ago. And what you thought about regurgitation, mild, moderate, severe may be clear, but what about the moderate tricuspid regurgitation in the context of mitral repair?
I don't have the answer to you. I can tell you that 7 years ago, I was repairing only severe tricuspid regurgitation. Now, I'm doing all the moderates together in the transthoracic echo when the patient is awake in the echo lab. And also, I'm not looking at tricuspid diameter. I think the guidelines are wrong for floppy valves. Might be correct for rheumatics, might be correct for ischemic, but I can guarantee to you if there's no relationship in myxomatous. I have 30 years experience with this, and size the annulus doesn't matter. However, diameter of the right ventricle matters. If you measure with the patient in the echo lab, awake, talking to you, if you measure right ventricular diameter and exceeds 30 millimeter, that's bad news. Even if they have no CR, they develop CR 2, 3, 5 years later. Remember, tricuspid insufficiency is a systolic dysfunction of the tricuspid valve. Why should the diastolic diameter affect systolic function if the ventricle is contractile? Valve dysfunction, mitral and tricuspid insufficiency, is a systolic malfunction of the valve. We should be looking at systole, not diastole, to predict outcomes.
Okay, we're going back to the final question to the mitral. How do you identify the the presence of calcification of the annulus and the extension of calcification of the annulus through the TE. You go to the cath lab to see how extension is the calcification in order to have an approach before going to surgery?
I do, particularly asymptomatic patients, because it makes the operation immensely more complicated. I learned, and we have a manuscript coming up in the Annals of Thoracic Surgery. The only reliable test to quantify calcium in the annulus of the mitral valve is CAT scan. X-rays overpenetrate, so it doesn't show minor calcification. Echo, you never know if it's scar or calcium. CAT scan can quantify the amount of calcium to the millimeter. It's pretty impressive. A soft CAT scan like you do for lungs.
Okay, and now we've finished for the last question, and thank you very much again for your opportunity to have this important comment from you. The thing is, what do you think is going to be the future for a young surgeon in terms of the mitral clip or the TAVI? What is your thought about that? In 5 or 10 years from now, the therapeutic impact they will have these two alternatives, TAVI and the mitral clip?
Prediction in Argentina or in Brazil, which is my native country, but I can tell you that in North America and Europe, TAVI is going to be the initial therapy for aortic stenosis, any age. This is going to make our lives miserable, because I have done now a dozen or so failed TAVI later on. I haven't lost a patient yet, but the operation is never an aortic valve replacement. In every case I have redone a TAVI after years of implantation, becomes a complex benttle. It has to be a custom benttle because the whole thing is screwed up. Frequently, the coronary artery have fibrosis, have a stent on it that you have to strip, put a patch on it. It's not a simple operation. Unfortunately, as they say, the cat is out of the bag, and the cardiologist is going to deploy aortic valve in everybody, including bicuspid aortic valve. And once they solve the problem with dilated aortic annulus, they're going to do for aortic insufficiency too. So you surgeon are going to be left with the complex reoperation.
Any thought about the mitral? The mitral clip is going to be the same?
Will never be a solution for mitral valve repair, ever. Because mitral regurgitation is largely, particularly in floppy valves, is largely a secondary phenomenon to annulus dilatation. Most human beings do not have a fibrous annulus, and those who have a myxoma degeneration, the annulus dilate first. The wall tension goes up, and the chorda tendina becomes either elongated or ruptures. So mitral clip might be a palliation for functional MR, reduce the amount of regurgitation, heart failure, but will never be for rheumatics or for floppy valves. There's a new trial now, and I'll bet you it's going to fail badly again. But every time you have a multi-million-dollar company behind the device, they're going to sell to the cardiologists. No matter what, there is no way to stop this. That's money talks, unfortunately. And cardiologist buys. So,
okay, thank you very much for your comment. It was a pleasure and honor to have you in our pre-Congress in Argentina. Thank you very much, Tyrone.